personal power, people positive, the community of connection. This is the Bob Jeswald Show.
Here we are with Dr. Hunter Champion, PhD, MD, PhD, part of Southeastern Cardiology. He works by day, sees new patients all the time, as he did today in clinic. Also affiliated with Emory Health, and certainly here to take your calls. This is our 100th episode, Hunter. Oh my!
I'm honored.
I'm honored.
I was in one of the first 5. I wasn't in the first one, so you've redeemed yourself by letting me at least be on the 100th.
Do you remember that?
I do.
It just seemed like yesterday, doesn't it?
Absolutely.
It seems like 100 episodes ago.
I had a much tighter hairline.
Yeah, is that what it was? That's great. So we bring you folks in. Some of them want to be brought in on video, but let's start with some questions first, if you guys don't mind. So Joey Moore is in here as well. So you guys can actually ask questions. I got to make sure I get this so I can see where the questions are. So I got to make sure. I can't turn this. You know what?
I'll just do it.
You can still do it. Okay, vertically. You can still do it that way. Okay, so
I think that's how they are.
it's not gonna. Yeah, I think. Oh, is that how they're gonna see it? Because they said, okay, swipe this way. Okay, that's what it was. Okay, rotate. You can't turn your phone on. Okay, so let's just see if it goes back. Hang on 1 second, folks, and I apologize because I can read it back this way. Okay, so if you have any questions, feel free to ask them right now. I'm gonna start out with Hunter. A cardiologist, wrote the book on broken heart syndrome. Papers, hundreds of papers, 300 plus. I mean, so many papers too. So your research is extensive, everything that you do. We asked the doc today for all you guys watching, and you know what? I got to shut off my Bluetooth. That could be the problem. Somebody's not hearing. That could be what it is. So I apologize. I got to shut my Bluetooth off. That's part of the reason. Okay. So folks, if you hear us now, Hunter's on. Go ahead and you can start typing out your questions, and I'll go ahead and ask them. So while you do that, I'll field some of them. And I apologize for the audio.
I think one thing that's important to remember: this should not be taken as medical advice.
Yes.
Even though I'm specially trained in internal medicine from Johns Hopkins, as well as cardiology and heart failure and transplant cardiology, everyone should talk to their own doctor, before making any medical change and that kind of thing. I'm really here more from an educational standpoint.
Right. Good. And just enlightening us too, perhaps directing us to another health professional to tell us where we need to go.
Absolutely.
And I'm glad you said that. There was something we were gonna talk about in just a minute. Okay. Yes. Cardiologist in Columbus, he is. Yes, he is. Okay. So I'm going to start out with one of the questions that were asked even earlier, too. Folks want to know, I mean, how old do you have to be? I mean, it sounds really common, but how old do you have to be go to a cardiologist? I mean,
so, it's
not a silly question.
No, it's not a silly question at all. In fact, if you think about it, when I turned 50, my primary care doctor did not let me be 50 for more than 12 hours before he's hounding me about getting a colonoscopy.
True.
And we have these stages in our life where you're a certain age, you're going to go get a pap smear, you're going to go get a mammogram, you're going to get colonoscopy, but we really don't have anything like that from a cardiology standpoint. So really, for the most part, in terms of insurance payers and that kind of thing, they really don't want us doing much of anything unless there are symptoms involved or if there's a good reason for it. So that's why your primary care doctor will do a annual EKG. If anything's changed there, then they say, oh, I'd like you to see the cardiologist. But normally it just boils down to symptoms. I mean, I saw a 16-year-old not too long ago. I generally stop at about 15 and let pediatric cardiology handle anything less than that. But I see people all the time that, palpitations. It's very common to have palpitations for some people in the younger ages, and that goes all the way up through the nonagenarian age groups and things like that. But really, if you ever feel like there's a symptom that is concerning for you, talk with your primary care doctor. Okay. Oftentimes, it may be something very simple or straightforward. It may be something hormonal. It may be something like thyroid. But then if that looks good, and they say, well, I'd still like you to see a cardiologist, then I think it makes a lot of sense for you to see someone.
So, the one thing I was always asking, you get the EKG, you go for an annual physical. Is that good enough, or do we should still say, hey, we should go see a cardiologist?
Well, you kind of have to couch it a little bit with family history. So there are some things that have familial predispositions. So if you have a lot of family members that have had a lot of heart problems in the past, whether it's heart failure, cardiomyopathy, those kind of things, then it might make sense to say, hey, your primary care doctor, should I see a cardiologist sooner and maybe get a screening echocardiogram or something like that? But really, like I said, mostly it boils down to symptoms.
Okay. Edith Coleman says age does play a role in getting she didn't finish the thought, but I think Edith is talking about probably getting like EKG, is it?
Sure.
Or something.
Yeah, and I think the key thing there is really, the older we get, the more likely we are to have certain things. Yes, we have young people that have coronary disease. We put a stent in a 26-year-old not too long ago who was otherwise pretty healthy.
Wow.
I saw someone, who's actually in their mid 80s. We did a coronary angiogram, and actually they have totally clean coronaries. So, it is a little bit hit or miss. Yes, generally things do track with age. As we get older, we're more likely to have problems with fluid management, maybe atrial fibrillation, other arrhythmias. Some arrhythmias, as we were talking about before, may be benign. Some may be more worrisome. And so I think at the end of the day, it's always better to err on the side of caution. Talk with your primary doctor. If they agree that a cardiologist makes the most sense, then by all means get an appointment. Certainly peace of mind is great. I tell some people, I said, listen, let's say we do the stress test and the echo and everything looks great. Well, great. We've got a new baseline on you and everything. Had a guy yesterday that we actually did a heart catheterization on. Everyone in his family has coronary disease.
Oh my gosh.
And he had
stacked up against him.
Exactly. He had a mildly positive stress test. We did his heart cath. His cath was totally clean. And I think at first he was a little bit upset. He was like, wait a second, how could that be? I said, what are you talking about? This is the greatest news you could possibly have.
Yeah, absolutely.
Kind of like Lieutenant Dan in Forrest Gump. He was upset that he didn't die in battle because all of his other relatives died in battle.
That's right.
Like, really?
That's the way it's supposed to be.
Exactly.
It's supposed to follow that. No, but we want to change that. And that's by being preventative medicine, which is one of the ways we do it, which is great. So, which is really good, too. We're looking at this right now. We have... Laura, go ahead. You can ask a question. Yes, you can. You can ask a question. Laura Cowart, we want to see if you have a question. Donna Cupp is watching. Any kind of medical question. If it's anything that Dr. Champion feels, he'll recommend what you need to do. He is a trained. He is an MD. He just happens to specialize in cardiology and has written many papers on that subject and much more. We talked about colonoscopies too. Folks, I heard you say 50 was kind of the magic word, but you're hearing now in certain kind of I want to say demographics, that wouldn't make sense. In certain kind of ethnic groups.
Yes.
We see that number lowering. What is
45?
45
in a lot of cases. So again, that's where your primary care team comes involved. And I'll oftentimes have people that say, "Hey, why can't you be my primary care doctor?" I say, "Because I do cardiology." I say, really that primary care physician is so critical because they're the ringleader. They're the one that really is kind of looking over everything, making sure that you're up to date on your screening and all that kind of thing. So I really do think that talking with them and coming up with the right plan with them is critical.
Awesome. And that does make sense. I'm getting even a little closer so some folks can hear a little bit better.
I have a face much better suited for distance.
And
radio.
We're liking it right now. So we're going to move me a little bit so I'm over here and out of light just for a second. So as we shine a light on this 100th episode of the Bob Jeswald Show, and you've been here several times, asking your questions is good. Let's see what she has. I'm going to read this right. Okay, so Edith says, I'm in my 70s. And my PCP always has, this is her primary care physician, questions. And let's see what else she says. And he's on point with my physical. Insurance plays a big part too. Is that something that doctors have to consider, Dr. Champion? I mean, and you hate to say you have to be dictated by insurance and how you treat a patient. That's right. There's truth to that, but you're still going to be, their best interest always comes first.
Absolutely. And I think that's the key thing too. And so, yes, I can tell you that certain insurances are more likely to approve just a treadmill test as opposed to treadmill tests with imaging. Certainly your age plays a role in that, but really it also boils down to symptoms and that type of thing. And I've had patients who their insurance would only cover a treadmill test without the imaging, which does only have about 70% sensitivity and specificity for coronary disease. But, I've had them when I've gone back and said, hey, listen, we did a treadmill. It was negative. Patient is having persistent symptoms. We really want to do a full treadmill test with the imaging. And oftentimes they will listen to us in that regard. Same thing with heart catheterizations. Sometimes they may not approve it, but then we turn around and they persistent symptoms and that type of thing. But really, that's more of our issue. I mean, that's my billing office's issue and and that kind of thing. And, and really, at the end of the day, I'm going to recommend what I recommend, regardless of what your insurance is. There are a lot of things that play into that. Things like deductible plays a big role. Remember, the deductible is something that you have to pay before your insurance will be willing to pay anything. So if it happens earlier in the year, then that plays a role. Your deductible may be a lot higher. And then the copay is kind of what you have to pay maybe after you've met the deductible as well. So, I just had a story where last year I had two people, both very interesting. They came in. They were having some chest discomfort. We made some recommendations. It was a little early in the year. They did not want to go through the testing, and we said, well, that's up to you. I'm here to recommend and suggest. And then sometime a month or two later, they end up going to the ER for for an MI rule out, where they go in with chest pain, and they weren't even admitted. But I think that their bill for that less than 24-hour stay was $7,000 or $8,000.
Wow.
So I mean,
that's crazy.
I said, well, you used up your deductible then, so now we can actually test and see if you've actually got coronary disease. And so there's a lot of things, and life gets in the way, and you do what you can. And I oftentimes will try to work with patients. Most all offices will work with patients, so I can tell you that our business office will work with patients in terms of deductible and copay. I certainly don't like taking big bites out of my bank account at any one time. And so sometimes we'll work out a payment plan or things like that.
I got you on that. That's for sure. Now, research has been limited. Folks asking about COVID. How much do we know has COVID just given us brain issues, heart issues? It sounds like very generic here, but is there any paper study, since they said you do a lot of papers? I wonder if you saw anything.
I've been on a couple of subcommittees and things like that.
Tell us about that.
So the research is coming out. Actually, what has happened is we're now seeing a lot of long COVID, and we've seen a lot of cases, particularly with the original Delta variant and the original variant. Those seem to be the one that were associated with by far the most long COVID. And really a lot of this ends up being more cardiovascular related. Certainly you come in initially with the pneumonia and that type of thing, but things that seem to keep coming up time and time again are things like arrhythmia, things like autonomic dysfunction, where your heart rate may be wildly variable.
Okay, this was going to ask.
You stand up and your blood pressure can drop and your heart rate shoots up. We see a lot of shortness of breath as part of long COVID. And as a result of that, now we have some clinical trials that are going on. So some people are looking at coenzyme Q10 to treat long COVID. We have, there's some other studies where they're just looking at other things like just long-term Aleve, long-term, aspirin or NSAIDs. Some of them are looking at there's actually a study now going on.
Why the long-term NSAIDs?
I don't have a good reason for that. I think they're just kind of looking at reducing long-term inflammation.
Okay, because it would be more inflammatory.
Correct.
Not so much thinning the blood or anything like that. Okay.
But then, and then there's some also clinical trials. Now, we do have a couple of really good long COVID centers in Georgia.
Wow, I did not know that.
Piedmont has one in Atlanta, and Emory has another in Atlanta, and they've amassed enough patients now that they're doing their own clinical trials. So if someone
you could be part of it, raise your hand now.
Absolutely,
Dr.
you can come in
says.
and really, and that's something you don't need a full referral usually. Usually you can self-refer.
Okay.
So you go in, you go up, they can evaluate you. And I've had a couple of patients who've been part of the clinical trials who've had very good success, and they say, hey, my shortness of breath is better than what it was. Obviously we have to kind of couch that, because a lot of what I also see kind of in the post-COVID era has been people who did a great job in the gym before COVID, and then everything suddenly shut down. And then, maybe have not gotten back to the same level of conditioning that they were prior to COVID.
And that is something that has a lot of people concerned, and that's why I think the reassuring part, what you're saying, is that research is happening.
Absolutely.
And there are masses coming in now, and that's happening in Atlanta and a few locations.
And I still hold out a lot of. I've always said that time is the great healer, and so if you wait something out long enough, it should start to get better. I can't guarantee how long that's going to be, but I can say though that a lot of the people who really had given up a lot of hope after a year and a half, 2 years, now come back and say, you know what, I'm starting to feel better. So that is a good thing. The good news is we see a lot less of that with the Omicron variant.
All right. Kay Keller-Skronik is on here from Buffalo, New York.
Oh,
friend
fantastic.
Of mine. Kay, if you have any,
Sabres.
Yes, there she goes. Go Sabres. There you go. That's right. Those Golden Knights. I couldn't believe I lived in Vegas for so long, and I couldn't even get an NHL team when I was there, for God's sake. I would have loved to have the NHL. If anyone has any more questions, please come on and let me know. Another question, it was earlier, I saw it, and I think you sort of answered it for him, but just to reiterate again, is that folks that have any kind of any flutter, just any kind of condition, you feel like something's not right, there's no shame in the game. Just hit up a cardiologist or go to your PCP. They'll tell you where to go, recommend or whomever you should see, wherever you're listening from. And that would be something smart to do. Arch, looks like Arch Smith is watching too. We got the judges watching and a lot of folks watching. So what my thing to me is when you said NSAIDs, you know how I am about that. It seems like medication a lot of times has some side effects. High milligrams dosage of over long term, I know can have some thinning lining of your stomach. In fact, I'm taking for some other issues I have Mobic. Okay. And I could say this, I took it, and by golly, it was better than Naproxen, Aleve, and I'm throwing out these name brands here, but I'm sorry about that, but it is what it is. Right. Aspirin always bothered me. I mean, it would burn my stomach after 2 days of doing it, so I always stopped. But it seems like it was doing well with food. what is the danger of something like this, a more potent, like a cataract or those kind of NSAIDs that are very, very, are you worried about that?
Well, always remember, and then we taught this in, my PhD is in cardiovascular pharmacology. So what we're always taught in pharmacology, the only difference between a medicine and a poison is the dose.
Okay.
You can drink enough water fast enough that it will kill you. Right? There was actually
been a couple of
there've been a couple of radio show kind of contests where people have actually died from drinking too much water too fast. So it all boils down to the dose. And really, I think the key thing here is no matter what it is, whether it's a nutraceutical, whether it's a pharmaceutical, whatever it is that you take, you have to remember that everything kind of comes with its own baggage. And there's no such thing as a perfect medicine. Every medication has some degree of side effects. It may affect a small amount of people. It may affect a lot of people.
Sure.
But when we think about things like the NSAIDs especially, we always worry about kidney function.
Okay.
Because long-term high-dose NSAID use can affect kidney function. But again, at the same time, you also have to weigh things against the positive. So if you remember, there were some of the NSAIDs, and there was some of the concern about risk of heart attack with Advil, with ibuprofen.
You always read that in the back. It scares the daylights
exactly.
out of you.
And if you remember, Vioxx was actually
Right.
and that was taken off the market. So, but you also have to remember too. And I have this conversation with people all the time. I said, listen, if you have to take a medication like Aleve or ibuprofen in order to be able to function. So if you need that so that your hips or your knees or your ankles don't hurt so that you can actually walk and do things, it's probably more stress on your body to not take it and not exercise than it is to actually have that relatively low risk of having a potential heart attack or something else from the NSAID. So again, risk versus benefit. Certainly stomach lining is something. There's a risk of ulcer with all the NSAIDs and things like that.
How long would you have to be on something like that before you run the risk of an ulcer? You hear that you're not going to get an ulcer taking it for a week.
Everyone is different. Certainly, I can say that the kind of the usual dose of ibuprofen for a lot of orthopedic issues is 800 milligrams 3 times a day.
Yeah, it's crazy.
That's a lot.
I can't.
That's
deal
a
with
lot,
that.
especially but for a week. I think that's usually not unheard of.
Okay.
But you also have to think like the over the counter dose of ibuprofen is a 200 milligram tablet.
It's so small.
It's exactly. So you think about, you have to take 4 of those 3 times a day. So generally speaking, and I try to caution people and say, yeah, but also too, just remember, you can take this every so often for a headache or take something for like some back pain or things like that. So I don't want people to be so paralyzed, to be like, oh my gosh, I can't take that at all. But again, it boils down to risk. I've had people get an ulcer within a week.
Oh wow, really?
Yeah. Steroids are bad about ulcers as well, and it's especially where people really get the high sphincter tone, if you will, is if they're on a blood thinner along with the NSAID or along with the prednisone. That's why if you actually look at the Mobic on the meloxicam bottle for Mobic, if you look at the back, it says you shouldn't take this with blood thinners.
Makes sense because you're double downing.
Well, if you should get an ulcer that starts bleeding, the blood thinners don't make you bleed, but if you have a reason to bleed, you'll bleed more freely.
That's where that comes from. See, I never knew that. I got some more questions pouring in here, and I'm sorry, guys. I know. Hey, okay, I was diagnosed yesterday. This is Kay Skronik. She says, I was diagnosed yesterday, and I'm so sorry to hear this, Kay, with AV junctional, there it is, AV junctional rhythm, and they say it was probably brought on by, let me see more, it's coming in here, by verapamil. And I look for a number. I'm reading this at an angle, by the way, everybody. Number of years, my eyes don't work that way. The number of years the doctor said my P waves are no longer before the heartbeat. So they changed her to amlodipine. Say it with me.
Amlodipine.
Amlodipine, which there's an L in here, which is another blocker. And her doc said I might be looking at a pacemaker. Now, how serious is this? And this is in your area too. I know this. And I've been asymptomatic, she says, at this point. So what should Kay do?
So that's a great question. So Kay has something that is actually, believe it or not, very common. And so I can't remember.
Wow, is it really?
I can't remember how old Kay is.
Kay, I know Kay. You'll shoot me. I think she's in her K. I'm going to say K 70s. So say early 70s.
So if you go back to Deuteronomy, the Lord said He gives us 80, right? So we get essentially 70 years plus or minus 10 if you're lucky. At least that's what He said in Deuteronomy.
Sure.
But if you look at it, when you get to about age 70 and you start looking at your peer group, every year that goes on, more and more people in your peer group start needing pacemakers.
71. She's 71.
There you go.
Okay.
So as you start looking around, so what happened? I think my personal opinion is, and this is just after 25 years of experience in this, what I observe is that I think the heart muscle is made to last for a longer time, but the electrical system, the nervous system in the heart tends to start wearing out oftentimes in your 70s. Now, my grandfather didn't need a pacemaker until 93, but
God bless him.
but some people need pacemakers in their 30s
amazing.
or 40s.
Sure.
But in this case, this is very common. So verapamil is a specific type of blocker that blocks at that AV junction. So where the top chamber of the heart beats, the lower chamber, it goes through, it's kind of like the nerves for the heart go into one little channel, and it goes to one little node. That's the AV node. And then that node then sends the electrical signal to the bottom part of the heart. Well, when that AV node is not working well from a medicine standpoint, so beta blockers can block that, calcium channel blockers will block that. So when we see this AV junctional rhythm, we take you off the blocker, like the beta blocker, the calcium channel blocker, like she was like with verapamil, and they change that to something called amlodipine, which is another medicine for blood pressure, but it doesn't have the same effect on the AV node and that type of thing.
Okay, so she's probably not going to, and if I'm hearing you correctly, it almost sounds like we're not going in she probably wouldn't have to get a pacemaker right now?
Well, it's not in a panic situation. I think right now, I think the key thing is what I would do in my experience is I would have her wear a monitor for a few weeks, especially since she's asymptomatic. So that's a really good sign.
That's good. When she said asymptomatic, I'm like, okay, I'm there. Yeah.
And then when I talk to patients about who have this, and just remember too, when the heart electrical system goes out, it's not like your remote control where suddenly you're changing channels and then all of a sudden it quits working on you altogether.
I love it.
So when the nervous system starts going out in the heart, it more sputters. So it's kind of like you'll start going slow, then fast, then slow, then fast, and then if you go into kind of a complete AV block, which is essentially an emergency that needs a pacemaker, usually people feel terrible with that. So they feel fatigue and feel like they can't do anything. Then they go to the hospital and they say, "Oh my goodness, we got to bring you in and we'll put in a pacemaker."
Gotcha.
More times than not, though, a pacemaker is put in more as an outpatient, where we're observing this, we're watching this, we've got signals that we get on the monitor, and we say, you know what, we're really close to having that. You've got some long pauses or things like that.
So monitor case, talking about she's going to have a monitor issued on Friday.
Okay, perfect.
So
perfect. So that's exactly what I would do. Whoever sees her is doing a great job, and then we monitor that, and then see if there's any sign of any sputtering of the heart, see if we're getting any tachybrady syndrome and that type of thing. And the good news is, like I said, people get so worried about a pacemaker. Of all the things we do in cardiology, a pacemaker is pretty easy. And
it seems so common. I remember hearing it. I remember years ago. I remember hearing in the 70s. It seems like it was a death sentence, but now it's very common.
And it's the size of a $50. I mean, it's really amazing. And if you're right-handed, generally they'll put it in on the left-hand side and the kind of
closer to the
shoulder
heart.
area. Exactly. And they put the leads down into the heart. It's something where now we're sending people home the day they get it.
Oh, for crying out
loud. So you come in, you get it, and you go home.
Outpatient procedure.
Yeah, exactly.
Technology is wonderful.
It really is.
Going back to the and I didn't answer the rest of it. Somebody else was. I'm getting texts, and I apologize, folks. I know we were telling them we're live streaming at WRBL, and we're not. So we lost some folks, but I'm getting questions on another thread here. They said, Bob, you didn't finish answering, and I didn't. I apologize. It's the natural medicines, such as like omega-3s. Fish oils are saying, are those considered something like meloxicam? You're saying that something is an NSAID in that family. Could that exacerbate? Could that cause more bleeding if you already have you got a predisposition of already having something that could bleed, and it just adds fuel to the fire, or not?
Yeah,
necessarily?
I mean, not so much. I mean, certainly there is a little bit of thinning of the blood with the NSAIDs themselves.
Okay.
There's a little bit, but it's really not a huge. I mean, we take a baby aspirin, and that's what we recommend for many people, a daily baby aspirin or that kind of thing. So I would say the amount of blood thinning that you get with the aspirin or the NSAID itself is actually pretty negligible.
Okay,
you may have a little bit of additional bruising, but generally not, especially if you're taking small doses.
Why does mine go in a square knot? No, I'm not kidding. It goes in a square knot. Yeah. It's nuts. I mean, when I sit there, I had to go into the ER one time, and I remember I was actually a broken foot. Years ago, I pulled a 25-pound plate on my foot when I was at the gym. This is in Jackson, Mississippi, years ago.
Trying to do the right thing.
Well, I was trying to impress a lady in the gym, I think, and I was still looking the wrong way. And my wife goes, "What?" I was dating Teresa then, and she said, "What are you doing?" She goes, "God, you came back. I couldn't even. My foot like it was 3 times the size, like an Oompa Loompa.
Your life was like a Mark Twain novel."
Yes, exactly. Yes, it was. Yes, it was. Right on that boat, I was floating down the river at that point, down in the Mississippi, But when they did it, they gave me like a high dose of probably ibuprofen, and my stomach went in a knot. Why did that happen?
Everyone is different, but essentially you can have issues with the stomach. In some cases, you may have already had some baseline gastritis. That then further irritates and that type of thing. So especially too, I mean, gastritis is incredibly common. So
Okay.
you can have problems with, nausea, that kind of thing, and pain, so, subdiaphragmatic pain.
Okay.
In those cases, then, generally we generally let that rest. I think some people try to worry about getting into a GI doctor very quickly. Just for the record, I don't do guts and butts for a living.
Okay.
I just know a lot about it. From
You
practical
do know
experience.
a lot about them.
A little
Because,
bit.
you touched a little bit on that
Right,
subject.
but like I said, I mean, oftentimes we'll put people on a proton pump inhibitor, some Pepsid, some Carafate, things like that to try to help soothe the stomach and give it time to heal.
Carafate's like a probiotic.
Correct.
Yeah, okay. So folks know. Okay, so now that we're talking about that, somebody you touched a little bit about gastritis, pancreatitis, somebody has some kind of adrenal issues. How does that get you guys, you're getting into that business of cardiology. I mean, cardiologists need to know the gastro side because sometimes something in that area is sorely mistaken for something cardiac related or something else. Tell me more about that.
Well, so referred pain is something that's very common. So you can have an appendicitis. The appendix is on the right side of the body, but you feel it in your belly button. That's a classic feeling. Referred pain, you always think about feeling the pain down the arm.
Yeah,
from
that doesn't mean
cardiac.
if it's the arm doesn't always mean a heart attack.
Correct. But, you start putting things together and you say, hey, this kind of raises my suspicion. My sphincter tone is going up thinking about this. So we should probably move that direction. But really, because anything, and remember, your heart is the size of your fist and it sits on top of the diaphragm, which is literally just inches away from the stomach.
Makes sense.
And then the esophagus comes up through the diaphragm and it actually touches the back of the heart. So you've got a lot of GI stuff right there around the heart. And I think probably 3 of the new patients that I saw today had been having some chest pains and things like that. And I just kind of remind them, I said, listen, you came to the right place first because no one's really going to want to touch it until everybody knows this isn't your heart.
Right.
So we're going to then do your stress test and and echo and things like that. And then if we come up with if everything looks great, awesome. I'm happy, you're happy. We then just need to do what we call a non-cardiac workup along with your primary care team to look for GI. And I will tell you the 2 most common things that we see. If you've got chest discomfort in general, and it's not your heart, it is going to be either GI related, so hiatal hernia, reflux, esophageal spasm.
So there's a lot more going on.
A lot of
you
things.
can imagine.
Gallbladder. I can't
Yes.
tell you how many times people have had a good heart workup and then all of a sudden they need their gallbladder taken out. And then we say, hey, again, this is great. You're low risk for the surgery. You can have the surgery without any trouble because we already did your pre-op workup.
Perfect.
Other things that we see a lot of as well, musculoskeletal. If you think about the ribs, we kind of all think the ribs come and touch right into the sternum itself. But if you ever eat ribs, like at the barbecue place, there's a pretty good bit of meat and gristle right there after the rib bone.
Just like us.
That's right here. And so that can become inflamed. The other thing, though, that we see, especially in our older patients or people who played football or other contact sports in the past, neck arthritis.
Oh, no.
So
that's a good sub. We're going to go on that next.
So neck
Sure.
arthritis, those nerves come down as well. So you can get numbness in the arm, you can get numbness and pain in the chest. That's actually a nerve-mediated event.
And right now, a lot of folks sitting out here. A couple other questions, you just answered that about the appendix and stuff like this. Say that you would work with a PCP. You guys do a workup. That was a good question. They said you went in and answered that one. Now I'm going back to Facebook. A lot of people watching Facebook, folks, too. Feel free to ask questions if you have anybody on Facebook, anybody else on the outside of that. And I, again, apologize for the WRBL.com stream. We're going to rebroadcast this. There'll be something out of this that somebody's going to get anyway, even if it may be a question you were thinking about. You touched on the arthritis from sports, some kind of injury, maybe beyond congenital, something that happened over time or you're born with it. You get a lot of crushing of the neck. I played ice hockey. We talked about ice hockey with the Sabres not too long ago. I played ice hockey for many years, wrestled, triathlons. I did a lot of sports, extreme sports. Did a lot of skiing, regular snow skiing, snowboarding. Out on Lake Mead in Las Vegas, did a lot of skiing too. So a lot of rolls and falls and everything else. Neck is pretty spent.
Right.
Bob Jeswald's neck is spent. You wouldn't know it, but boy, when it acts up.
That'd be a great sitcom
I
title.
know. How could it go? How would it go? Would that be one of the? What's the line you said? That would be a sphincter tightener, or whatever.
Exactly.
Yeah.
Right.
So what would happen with that? The Bob Jeswald what? The neck.
Bob Jeswald's neck is spent.
Neck is spent. Does that sound like maybe CBS can do that? I don't know.
Maybe
So-
more HBO. I think we could work a little more blue.
Yes,
So-
exactly. Yes, so let's go with the max. That's right. We can get away with a little bit more, more talk and more openness. I would think FCC won't jam us for that. There you go. So, I like the fact that with that whole neck thing and understanding a little bit better and MRIs, and we get all these great things. Recently, And over time, and I had seen a cardiologist, in fact, saw you guys in your group, and I talked to you about it. I think it was Dr. Dare. I saw you several years ago. That I thought before I did a triathlon and I was doing a run, it was actually, this one was particularly a marathon, but I did the half. And I was concerned because I kept getting this tingling and everything else. I knew I had some kind of neck stuff going on possibly. I had shoulder surgery, whatnot. But now it's to the point, it seems like it's spinning out of control. So I get an MRI and stenosis and arthritic conditions in there, myelopathy and starts with the R, radiculopathy.
Radiculopathy. Right?
Yeah, it's ridiculous. I can't say that. And that continues to go on those nerve roots that are being pinched that go right down through the neck, shoulder, and the side of the arms, as you described. And you would think sometimes you're having a heart attack. I said this to you jokingly. I would say, geez, Dr. Champion, I just run into you. I go, God, my front chest is tightening. Well, Bobby J, that could be from your neck,
Right.
And finding out that now that seems to be the case. So folks that are experiencing this, maybe orthopedic-wise or neurosurgeon or something like that, they should check into that as well.
And we're very fortunate in this community. We've got some outstanding neurosurgeons and outstanding, obviously with Houston Clinic and the St. Francis orthopedic groups. I mean, we've got great orthopedics and great neurosurgeons. If you ever saw, like if you ever did an autopsy or if you ever did like a cadaver work, like we did in an anatomy class, you would be amazed with the holes that these spinal nerves come out of in your vertebrae are tiny. And what comes out is almost like spaghetti, like limp spaghetti. I don't see how in the world we don't rip nerves apart just turning our head quickly and things like that.
Crazy, yeah. And that's why you get it in chiropractic. Somebody's asking, are chiropractors okay in this? It just popped up and it disappeared. It was on another thing. So I know what they were saying because they're listening to us live. So chiropractic. I know there's neck manipulation. There's things like that. I've gone to a chiropractor. It works great. There's different things. Sometimes they want to extend or hyperextend the neck a little bit in a way where you, it's kind of like some type of neck therapy where you extend that vertebrae. You go to physical therapists. I go to physical therapists too. What's the deal with that?
So certainly chiropractic has a role. I think a lot of people do get relief from chiropractic. One of the things I think that's key is, I think I mentioned this before, we're all a quarter inch shorter at the end of the day than we were at the beginning of the day. Because when we lay in bed, the water that is in the discs of our vertebrae, in between our vertebrae, they expand. So, but as you're standing up and you get that pressure coming down on each disc, you lose that water, so they become smaller. So what I do is I actually have a teeter, one of these inversion tables.
Oh, I saw one of those at one of the sports places. I got
to say, for me, it was an impulse buy. It kind of showed up on Amazon. It was like 70% off, and I said, how can I resist this?
Because they're kind of expensive. I mean, they could be $400 or $500.
Exactly.
I've seen it,
But this thing, you lock your feet in and you can control it. So, my wife is always worried that I'm going to get up and, I can't do it. Exactly. But no, but what that does is that actually helps open up your vertebrae and helps open up your discs themselves. And so I find a lot of help from that. What my father does, though, he actually has a traction device. So he got this thing off of the internet, and essentially it attaches to the door. He lays down and it just puts gentle pressure on his neck.
Fabulous.
And there's some that you can actually
hydraulic. You can
it's
lie
kind of
down.
like that.
I've seen that.
Exactly.
Use that too.
Some of them are also a little bit easier. They're you just put it around the neck and it's inflatable, and so it can slowly kind of give you that little bit of traction. And sometimes that's all it takes.
So that can add inches to your height.
Maybe I don't know. I don't know if I'd use that as a height enhancer.
Okay, well, it's
probably better off with lifts in your shoes.
Better off, yes. And you can buy those. They're cheap. I actually had a pair one time. So if we're talking about that, are there naturopathic ways, in your opinion, as a medical doctor, to do something where maybe surgery could be an alternative? And I'm in my case, and I'll share this with the audience openly. I have a classic case, and through other opinions, some think I can hold off, but it's a matter of, Bob, it's not if, it's when it's going to happen. I have C3 to 7 in my cervical spine. That's looks like an hourglass shape, and I'm gonna come right to you. I'm gonna go ask somebody. They got a question here, and so it's so bad that the nerve roots are getting crushed. Am I gonna get pinched? Is it gonna hit the spinal cord? Is there anything you can do naturally through these things you said, contraptions or devices that I can extend or maybe widen the gap between the vertebrae?
So I think the key is to have a conversation with neurosurgery or orthopedic. Get those images like you did, and see how much time you have. See, because there are some things we say, look, this is not at a level where we need to do anything about this yet. I'm a firm believer in trying to avoid surgery as long as you possibly can, but at the same time, it's kind of like throwing a football pass. You want to hit it at the right time, not too soon, not too late. And so that I think that's the key thing. Working with and actually I think probably the neurosurgeons and the orthopedics will probably have a lot better ideas than I do. do. I can just tell you that I do the teeter, and my dad does the traction on the on his neck. But they may have some better options for you in that regard.
I appreciate that, and that's what I'm in the process, and if anyone else watching, do that too. Okay, so we have somebody here. Okay, this is one of your buddies here. Any recommendations, treatment for fecal incontinence?
So that's a great question.
Great question.
So fecal incontinence is something that happens more often than you would think. Certainly, we think about that pelvic floor is something that has really gotten a lot more press. We think about people doing their Kegel exercises.
Sure.
Both men and women should be doing their Kegel exercises.
So people know that they may not be savvy of that during pregnancy with your wife too.
Correct.
You're tightening up your rectal area.
Correct.
Yeah.
But I will tell you, there's a lot of, the rectal surgery group and things like that have got a lot of good, got a lot of new things they are doing with regard to rectal incontinence, whether it's injections in that area and that type of thing to try to help with fecal incontinence.
Great, wonderful. Folks are saying thank you very much. That was Jed, by the way.
Yes.
Want to let you know. So you've been a real big help, and this is going to help me with questions for my primary care physician on my next visit. So thank you. You're getting thanks for that. And folks, too, on Facebook, feel free to. Facebook folks, if you'd like to add more comments and whatnot, feel free. Bring them in here. And I'm zipping through these a little bit fast. Looks like, it's funny how you're answering questions as we got in, and it looks like they got that question. Let's see. Good. So my question is, we're talking about going back to the neck. What is a good workup that everybody should have every year? The way our society is, you think we should be able to cure cancer. To me, it's so ridiculous, considering the things we can do. If we could come up with a fast path to find, a treatment or mRNA when COVID happened, even if I don't even want to debate if it worked, if it didn't, if it was BS or whatever. Sure. The point is, the government was able to work it through. Isn't that funny how fast we can get through the red tape? And rightfully so. This is a pandemic.
Sure.
But so is cancer is a pandemic, in my opinion. I always think about this. Gosh almighty, cancer comes in so many shapes and sizes. So many people die every year. It feels like it's unnecessary. Could that be? Is it in your every ounce of your soul? Could you say, couldn't there be a cure for cancer? How can there not be?
Well,
why not?
Recognized in the last decade, we've actually had a couple of therapies that have actually, for all intents and purposes, have become a cure. So there are a couple of things there. I think one of the problems that we have with cancer in general is just like trying to play 5D chess, right? Because you have not only when you catch it, you have what the genotype is, what are the genetics behind it. What is the tissue involved? And so we've really gotten a lot better though with a lot of the genotyping. There's a lot of for lung cancers, if you've got this genetic marker, breast cancers. If you've got this genetic marker, then we know this therapy would be better for you than another therapy.
There's more to it. So my question, and I'm being kind of anecdotal, but looking at that is because people are thinking this, but there's more to it. There's very specifics that go into that. There's certain cancers that have to be treated a particular way.
Sure.
When you call someone like my father-in-law died of stage 3, and a stage 4 colon cancer. It was in his liver, but he died of colon cancer. Even though you'd say, well, your liver had the cancer, the spots. So that's how you determine. There's different ways of treating that.
Sure.
You can't treat it like somebody down here treats it. So it's more complicated than what it is. What you're saying, but early detection.
Early detection. We were just talking about people, in some cases moving your initial screening colonoscopy to 45 as opposed to 50.
Yeah.
And so I think that's the key thing is one, trying to catch it earlier, and then knowing what you're going to do once you catch it, and how much is involved.
Okay, that's good. So I never heard of a push pop sizer. Have you? Inside joke.
Right.
Yes. But anyway, so we just wanted to say that's just something we can get a little loose here. This is the folks that just want to kind of come in here. So it made you blush.
I did.
I made Hunter blush. That's great. I've never seen. Have you ever seen him, Axel? It's the first time I ever made you blush.
I'm actually sweating.
I cannot believe.
I'm greasy and I'm sweating.
You're the same color as your suit jacket.
That's exactly right.
And you even had a sip of your Starbucks coffee.
Right.
Oh my gosh. Okay, I'm sorry. I just had to play with you. Folks understand. We're just having some fun here. But I believe that when you go out and do early detection, there's so many people that are stubborn. There's so many guys that don't even get their prostate checked because they're either ashamed or feel kind of funny. I don't want the finger wave.
Right.
What's wrong with that? Really, I know that doesn't necessarily, that's not everything, though. People got to understand, there's, just like we said about cancers, there's many different things you have to do to get to that point. Is this truly cancer or is it not?
Well, I will tell you, one of our biggest advocates locally for early cancer screening was a patient of mine who had metastatic colon cancer. And whenever anybody would ask him about it, he said, yeah, and he had carried around a pump with his chemotherapy. He said, yeah, I've got metastatic colon cancer, but it was my fault. He said, he said, it was my fault. He said, they kept bothering me about doing a colonoscopy, and I always found an excuse, right? My mom used to always say, tomorrow's just an excuse away. You can find a reason not to do something.
Sure.
And so he did. But then eventually he ended up having metastatic colon cancer. And so, but I think a lot of times what a lot of people realize is, you know what, you really shouldn't be putting this stuff off. We recommend it for a reason and that type of thing. And I always joke with patients, well, I'm going to recommend this, and if you don't do it, I'll tell you I told you so if something bad happens. And I'm not really an I told you so guy, but it does send home the point. Say, listen, and I'm also fascinated by patients who will they'll make the effort, they'll come see you, but then when you tell them what's going on and try to explain it, and then you make your recommendations, they say, well, I'm not doing any of that. So, okay, well, I mean, as long as you understand the potential risk and benefit of your decision, that's up to you. But yeah, I'm always fascinated by I think sometimes people just want to be told everything's fine.
Okay, what about docs? I mean, my question is to you: you guys work long hours?
Yeah.
When do you guys get there? And say, how do you guys take care of yourselves? Because you never. What is it with doctors? Seems like you never get sick.
Well, you know what? A lot of us don't. A lot of us don't take care of themselves. I mean, seriously.
This is interesting. Why is it?
A lot of us don't take care of don't take care of themselves. I think a lot of it is there was this old saying, "Physician, heal thyself," and we always joke whenever we see a nurse or a doctor coming to see us, we're like, well, we're the worst patients.
I know, yeah.
And that type of thing. Well, and there's this perception that we should never get sick, right?
Right. You're not supposed to. Like your immune system is already, because you've been exposed to it.
I don't have a family history of coronary disease. I did a full cardiac workup on myself within the last 2 months because I didn't want to be the cardiologist that needed bypass surgery.
Right.
Because then patients would be like, oh my gosh, well, if he can't take care of himself, how's he going to take care of me?
I got my meteorologist with lightning. I go berserk about lightning. If I'm sitting there preaching about it, telling you go indoors, you hear it, you're in striking distance, and I say to my kids, don't embarrass me, gosh darn it. You better run when there's lightning, get in a safe spot, and you should know it. And coaches drive me crazy. I always have to do the little jabs in the coaches.
Sure.
They want to stay out there and practice with these kids.
Right.
I want to strangle them. Seriously. Right. It's the most idiotic thing. It's stupid. You're exposing these kids to a threat. But you as a doc, people are saying, geez, I go to him. He shouldn't have cardiac issues.
Right.
But it happens.
But everybody does recognize. We're human and everything like that. And I think, at the end of the day, we do get sick. I mean, and that kind of thing. It's just, I kind of downplay it probably a lot, and that kind of thing. Heck, I had a car wreck 15 years ago and almost died. And to this day, whenever I stand up, my blood pressure drops to about 80. So I get
you had a horrible
wreck. So I get cut my neck severely. So I get I get dizzy all the time. I'm one of the few golfers whose golf ball moves, and so but I deal with it a lot better. And I think that's a little bit of the stoicism of being a physician is kind of like there's nothing wrong here.
But do you diagnose yourself, or do you go to another? Do you go to a physical? Do you get your physical to somebody? Who's your?
Absolutely.
You go to a doc. You have a primary care physician.
I've got a great primary care physician, Dr. Berman. He's outstanding with Horizons Diagnostics, and
I go to Dr. Carmen.
Oh, there you go. Yes. And so, although she went from Kettle Hut to Carmen,
I was like that, just 2 Ks, but it's okay.
Exactly. But I'm finally getting used to it.
I know. I still call her Kettle Hut.
And we're very fortunate in this town. We've got some great primary care physicians, and some of them are retiring.
Right.
Banks Carroll retired, but we've got great new people coming into town, and they're outstanding. And so I think finding a good primary care physician or a good cardiologist for that matter is like finding a boyfriend or a girlfriend. You got to find what works for you. And I will never read the reviews. Because I will.
Okay, so that's a great question, and I want to go ahead and finish your thought because that's interesting.
I will never read the reviews on Google because I will tell you why.
Yeah.
Or Doximity, because there could be 500 amazing reviews, 5 stars. It's the one person that said something nasty about me that I would ruminate on for the next month and a half, and it would just tear me.
So it's not fair. So I'm just glad I don't have that with us. Weather. Hey, his weather wasn't right today. It was not. Oh, we're his most accurate team.
Right.
Well,
and listen, I fully recognize, even and logically speaking, not everybody's going to like me. I go sulk in my office. And,
I don't know anybody who doesn't like you.
Well, I mean,
come talk to me.
Well, like I said, I mean, it's
nicest guy.
Well, we do our best, but again, I mean, you got to whoever you choose. You want to have someone that is your same mindset. I'm someone when I first see somebody, I say, look, I don't want you on any more medicine than you need to be on, and if we can get you off something, I'd love to do that down the road. I'm not someone who just throws a bunch of pills at you. If someone wants a doctor like that, that's not me. And so, and the other thing too is, I think the other part too is I think a lot of times people feel like, physicians are Western medicine only and are like, no, we only use pharmaceutical medicines and things like that. I had a husband and wife, and the husband said, well, I have a holistic doctor and I don't think she needs these pharmaceuticals. And I said, listen, I think there's probably a place for both in this world. I actually take a number of vitamins and
So do I.
supplements
Yeah,
and things
right.
like that. But at the same time, we have medications that have been gone through rigorous testing and double-blind placebo-controlled trials and things like that we know will work. And so I think there's a happy medium where you can be on prescription medications and then also supplements.
That's good. And we're going to wave. Liz Yarborough Guild says, I love you, Dr. Champion.
She's
We love him.
outstanding.
Yeah. Lisa Amerson's on right now. We still, you folks, go ahead. I know some of you have some questions here. We got Ida, who's here too. And folks also are, they were asking us earlier too, how, it's maybe personal a little bit, but if you see something and is there ever, not that you want to be, you're okay if somebody gets a second opinion, that's what they're saying.
Yes.
Does your feelings get hurt? It seems
No.
like there's a code with doctors.
No.
Is there a code with doctors? Because a lot of people they're kind of apprehensive. And doing that, don't be apprehensive because you got to make that clear decision.
Listen, there are two types of physicians in this world.
Okay.
There's the type that'll get huffy if you want to get a second opinion and say, oh, well, if you don't trust my opinion, then you should just get to stepping.
Right.
But I'm on the other side. I said, listen, I trained half of Emory and Mayo Clinic when I was at Hopkins and UAB. I said, if you are at all uncomfortable with this plan, you should go get a second opinion. Okay. And because at the end of the day, you need, and I tell people all the time, if you're going to go into a surgical option, you want to be 100% in.
Absolutely.
And if there's any doubt in your mind, go get another opinion. I tell them, I said, look, you want to pay $25 for half a day of parking in Jacksonville, that's fine. Hell, I'll even make the referral. Yeah.
Good.
But again, I want you to feel comfortable. And I will tell you, there are certain cases where I can't figure out what's going on. And I say, listen, this is outside, my realm here. I said, let's get you to a kind of a quaternary care center like Mayo or Emory or Piedmont or UAB or Duke, or even Hopkins, and maybe they'll have a better chance of finding what's going on with you.
Is a third too many? If you get two that are diametrically opposed, I want to say diametrically opposed, two that might be just a little bit off. Do you get a third, or are you just getting out of control?
No, well, then you
When
kind of
do you stop?
Then you can't go, well, I'm going to take the best 2 out of 3. I'm going to take the best 3 out of 5.
Yeah.
That's 5 out of
I mean,
7.
yeah,
That's
okay, I see your
kind of
point.
Then it's kind of like the NBA playoffs. And,
Sure.
and at the end of the day, I think you're just trying to find how many people. I think you're trying to find somebody that wants to say what you want them to say.
Is that what that comes down to?
I think sometimes.
So you do. So there is a little psychology with being a doctor too. You got to read people. What is your type of patient that just drives you crazy? Just somebody saying, what are the ones? So yes, and I don't even know. I want to say their name. Maybe this person drove you crazy, but no. What was the one your type of person that you would think?
Well, here's what I'll tell you. I
Okay.
mean, 95% of my patients, really almost all my patients have my cell phone number. So I'm the easiest physician to get a hold of in this world. All you have to do is text me.
Okay.
I don't answer my phone.
I'll test it.
I don't check my voicemail.
Yeah, right.
But if you text me, I answered 4 texts when I was in the parking lot waiting
I had to come
in.
out. Listen, folks, I got to be honest with you. I had to go outside. Axel knows this. I got to go get Dr. Champion. He's not coming in. So no, but it's good. It shows you're passionate.
And 9 times out of 10, it's an easy answer, right? I don't like the idea of someone having to go through the phone tree line and leave a message that may not get answered for 24 hours and that kind of thing. So what bothers me is when patients will kind of go on their own and say, I'm not going to do this. I'm going to stop all this and then and not let me know. Yeah. Or I have a lot of patients that have heart failure. So, I have patients, I always tell patients, I'm going to treat you like family. Now, sometimes family needs a cussing out. And if you need a little cussing out, I'll give it to you.
Okay.
But it's always done out of love. I say, if I didn't care about you, I wouldn't even talk to you.
How often do you fire patients?
Really, oftentimes, for me, firing a patient is almost never an interpersonal issue. It's almost always not showing up.
Okay.
So and what I tell people is, listen, I said, it's one thing if you don't show up, so you didn't show up for your stress test, so you didn't get your stress test. Well, for me, what I'm most upset about is we held a spot for you.
I'm totally there with you.
That someone else who really needed it so they could get their neck surgery could go in there and you deprive them from getting that.
That could be me, by the way.
Well, right. So
did you use it as an example? Were you thinking of
yeah,
me when you
literally,
said it?
I
Were you
was.
thinking of me?
I was,
okay.
absolutely. So, but like I said, I mean, for me, really dismissing a patient is almost always a business decision from the billing office and the business office, just because I mean, and it's a partnership. So if and things come up, so it's not like oh my gosh, my car broke down. I'm scared Dr. Champion's going to fire me. No, things happen. So one no-show is not a big deal. But if it's perpetual and habitual, then we have a problem. And at the end of the day, it's just if you don't respect if you don't respect us enough to let us know that you can't come in or you want to reschedule, that's one thing. I mean, but at the same time, there has to be that give and take.
Fair.
And especially too, what I don't have happen is someone ends up going off and having a heart attack and dying. When somebody comes back and says, well, why didn't you call them 20 more times to have them come in? They should have known they should have been coming in. They've got something concerning. So yeah, like I said, I mean, it's just one of those things that, I mean, I hate losing a patient, but kind of and sometimes I'll talk to them and I'll say, hey, listen, hopefully you'll get a better relationship with someone else. And heck, we got other great cardiologists in town. I'm not the only one in town. So it's not like, it's not like I've got a monopoly on the whole thing. Yeah. And there are other great cardiologists in town and that type of thing. And so maybe you mesh better with them. And
so a lot of times it's personality driven.
It is almost always personality driven. And also to remember, when there's conflict, it's usually an expectation that was not verbalized that was then as a consequence not met. So
I like that.
So
this is a psychology that the docs, which is good at. You need to understand that.
Right.
Some could be ego, some may not be, but somebody just needs to listen. And I totally agree. And also agrees is Ralph Tolan said he's so glad that his primary care physician sent him to you.
Oh, I appreciate that.
So a lot of comments.
I
A
owe
lot
Ralph
of these are
$5.
just a lot of positive comments and stuff, folks, and answering a lot of them, and are thanking you for that. Another one came in on my personal. I'm trying to see if I can read that one too. It's hard to read because I'm in a stream here too. I think I got the gist of that. Okay, not a cardiologist question. Okay, arthritis and heart. Is that a sign? That's a good question. I know what they're saying. Is arthritis somebody who has chronic rheumatoid arthritis? Does that mean they're running the risk of having something wrong with their heart?
It's a great question. So there's a couple of reasons. So any type of inflammatory condition, any type of rheumatoologic condition.
Ooh,
So rheumatologic conditions, whether it's rheumatoid arthritis, lupus, scleroderma, mixed connective tissue disease, Sika syndrome, Sjogren's, any of those types of conditions. In fact, kind of really what I say is if someone has a reason to walk into a rheumatologist and keep a rheumatology appointment, they really should be screened on an annual basis for something called pulmonary hypertension.
So that can be hypertension from that's
absolutely
crazy.
11% of people with rheumatoid arthritis will end up with pulmonary hypertension or high blood pressure in the lungs, and that causes shortness of breath, fatigue, and that type of thing. Up to 40% of people with scleroderma will have pulmonary hypertension. So there's this huge initiative that we've been doing with the rheumatology groups to actually look for and screen for pulmonary hypertension.
That's scary. But so would it be prudent? You would, if anyone who has it, maybe just let's jump on board and see a cardiologist like today.
Absolutely. But really what you want to do is you want to see someone that really has an interest in pulmonary vascular disease like us. So we actually do two tests to screen. We do an echocardiogram and we do a cardiopulmonary test. And we generally will do that on an annual basis. Oftentimes they would also need some lung function tests. But that's something that we do on a regular basis because pulmonary hypertension, just like anything, if we catch it early, we've got a much better chance of treating it. Because with pulmonary arterial hypertension, which is what a lot of these are, your risk of dying, your 5-year mortality is actually on par with most cancers.
Wow.
So that is
in anything with inflammation, it just attacks those areas of your body that might be weaker than the other. Right. I mean, you might be more susceptible in the lung area, more susceptible somewhere else.
Well, we know that these markers that you measure like CRP, C-reactive protein. Yeah. If that is elevated, you've got a higher risk of having coronary disease. But it can also be elevated for other inflammatory reasons. So what I get some consults, people who go in with a pneumonia, they get a CRP measure, it's like 20 times normal. Right. And they're like, oh my God, it says I could die. Exactly. So then they make an appointment.
White blood cells, your monocytes, things like that when you get a blood panel workup. So you go see your PCP and make sure you get that. You're sick. And that comes up high. Usually that's nothing to be worried about. Then sometimes those things that'll show it's high, it's a little bit off the chart, may just be, there's a reason behind it.
Right. So generally you kind of already know that. Usually there's something, sinus infection, that kind of thing. But that is something that you also track with. But sometimes, we can have some leukemias show up as a very high white count.
Oh, wow.
So
So those are
that'd
your
be
white
some-
blood cells.
Correct.
They kind of eat up all the real bad. They're supposed to eat
Exactly.
a lot, but if there's too many of them,
Correct.
then there's your body saying, well, your bone marrow is producing too much because it doesn't
Correct.
like what's going on in
Correct.
your body.
Well, that, and then also too, on the blood panel, the other things that I really look for more as well as the hemoglobin and hematocrit. So that's your blood count.
Okay.
So
So it goes all in one. You don't look at just one portion.
Correct.
Okay.
Correct. Now, everybody looks at their own lab work, and they want to make sure there's no H's or L's right
Yeah,
down the
right.
side.
No
of
one
everything.
wants to see that.
So, but there's a lot of things too that are on those red blood, on those blood panels that really don't matter much. So that's where you talk with your primary care doctor, or like I said, if you have a question about your blood work, just text me.
Just text
yeah,
me.
just
See
text me.
how easy it
And
is?
Say,
It's the
Dr.
easy button. Boom, he's there.
Dr. Champion, my red cell distribution width is off. Should I be concerned? I said, hell no. That's not something I worry about.
Debbie Sheffield says the same thing. I love you. She says, Debbie, along with everybody else that's on here, and our other locations too. Here's one, ED. Hey, it's a tough one to talk about.
No.
But guys asking again, does ED mean, and we've talked about this before, I know what the answer is going to be, but for our listeners and viewers, does that mean you have a heart issue pending?
So this is something that I actually know something about. Okay. So when I was in New Orleans, we had the only in vivo model of erectile function.
Okay.
And we did all the preclinical work for Viagra and Cialis. And my research was part of the reason why Viagra and Cialis are now approved for lung conditions like pulmonary hypertension, because that was my thesis.
Okay.
It's actually that same enzyme actually was in the lung, and we didn't think it was in the lung at the time. So then when I got to Hopkins, we started treating all these people with Viagra, high-dose Cialis, and we were seeing great effects. One of the things I also did when I was up in Baltimore was it was right around that time where, and actually I helped invent something called Muse therapy, which is an intraurethral alprostadil, treatment. It just so happened that it got approved the same year as Viagra. So everybody started taking Viagra. Nobody worried about Muse. But with ED, so part of what we found was everybody tried Viagra. Great. But then they realized, hey, wait a second, it's just not working for me. So I had a full clinic in Baltimore, and kind of like, if you remember Shawshank Redemption, when Andy Dufresne would do people's taxes when they would come through the softball circuit?
Yeah, awesome.
Well, we had kind of the same thing. Whenever a lot of people would come in to play the Orioles, a lot of the coaches and some players would come see me, and we would look over everything. And so really, yes, erectile dysfunction is kind of like the bald eagle, if you will, of the body, and erectile function is. And so if you think about it, if the environment if the landscape is not healthy, then the bald eagle will not survive.
Interesting.
Right?
Makes sense.
Same thing here.
Yeah.
If you start having erectile dysfunction and nothing else is going on, that means something is off. And so things that we recommend. If you have erectile dysfunction, let's look for an organic cause. Now, there can be psychosocial causes. A lot of
so you're not even thinking of psychology.
No.
See, I never even thought of
what we've been finding a lot of, and what we've been seeing a lot of, has been things like pornography addiction. Mm-hmm. So people have such access to pornography that they essentially just use up all the dopamine in their body.
Now they don't want to come to bed with their partner or spouse.
Correct.
They're going to like, I'm not interested.
Correct. So that's part, but it's not necessarily an I'm not interested thing. It's more of an actual physiologic.
So you burned up all your testosterone.
Correct.
Or your
exactly. The dopamine.
Dopamine.
Right. The dopamine is kind of that neurohormone that really kind of is kind of the pleasure center, if you will, or it's a reward.
Okay.
But things like cholesterol is important. Things like blood pressure is important. Things like your testosterone level. So one of the things I recommend for a lot of men, get your testosterone level checked. Sleep apnea is a big one. If you have sleep apnea, there's a central effect to reduce your testosterone levels. So people say, well, gosh, I'm just getting fat. I'm losing my muscle. I'm gaining fat. I'm snoring louder, all these kind of things. Well, if you get started on sleep apnea treatment, testosterone level will come back up. You start gaining muscle, and then it kind of is a positive association in a good direction. And then in some cases, people still need some help, like Viagra, Cialis, that kind of thing. But like I said, get your cardiovascular system in order. Get your house in order. Exercise improves erectile function.
I've heard that.
Exercise improves as well.
Good too. You're getting your blood circulating. For women too. Women want to know. So this isn't just about males. They're
Absolutely.
what about ladies?
Absolutely.
So women, the same principle, different kind of levels, get it checked.
With women, it tends to be more of a sensation effect. It tends to be more anorgasmia, or taking an incredibly long time. And every woman is obviously different, as are men. But certainly certain medications can have an effect on your sexual function. So certain antidepressants can certainly decrease your libido and that kind of thing. Certainly think about this. I mean, we talked about Susie Westerland not too long ago as well.
Right.
Hormones, when women are going through perimenopausal times, a lot of times they lose their testosterone is 0, and women are supposed to have some testosterone. Right. And so Susie does a great job, as do other GYNs in town, of being able to manage hormonal levels and things like some estrogen, some progesterone. So, and I'm getting out of my wheelhouse a little bit. But then we have women that come back and say, oh my gosh, this has changed my life in terms of, I was just thinking like, Jesus, is this what the next 30 years is going to be like?
So age shouldn't matter is where you're getting at. This. Again, when we said this before, that age is going to happen, but why not get it checked out? And you can get it checked out. Right. We said Dr. Susie's one of them. Right. And we talked about that in some of our previous episodes as well, as you want to dive into and find out. There was one with you and Sue. So if anybody wants to see that one, we get we deep dive into that. So, but that was good. I think the ladies just felt a little left out there. But no, you're just as important on that one too. But as far as we talk about that, kids. You hear about all the vaccines. Somebody's asking, but what about vaccines? The latest with teenagers. You're hearing some of the side effects of vaccines. Are you worried about vaccinating a kid against any kind of sexual transmitted disease beforehand? The what do you call it?
The HPV
virus. We're giving it to 14-year-olds. I mean, some people may be looking at it as a preventative. Look, my kid, they're kids, they're teenagers. They're going to sneak around. They're going to get into a sexual relationship or whatever. Or we can't police them all the time. Those that won't. Is it more for that, or is this something that we have to be so careful about?
Well, I will tell you. So I think there's a couple things there. One to unpack. I think one is just the condition with HPV. I mean, HPV is now one of the biggest causes of throat cancer in middle-aged men.
You think of Michael Douglas.
Absolutely,
actor,
absolutely.
Right.
And so in fact, he brought a huge amount of awareness to that. Yeah. So if we can prevent throat cancer in people down the road, and also I think part of the concern is that people say, oh, well, if you give them this vaccine for HPV, you're essentially saying, well, go out and have all the sex you want. Right. And I think that's different. I think, again, I'm not going to be someone that's going to preach how people should parent, because every kid is different. I mean, all three of my kids are completely different in terms of reward and punishment and all of that. They're great kids, and they've turned out great. But at the same time, I think you do have to think, because you really also don't want to start vaccinating people after they've been infected with HPV. So that's why they picked 14 as kind of that initial.
That
initial
answers that question.
Point.
I hope they answered that person's question. I'm sure it did. I didn't see any other response after that, but that makes sense.
But as with anything, though, I mean, this all requires a great conversation with the kids, and I think and you always come back to that, and you always come back to saying, hey, you want to have a good relationship with your kids, and you want to have an open relationship. I mean, there's a lot of people who are like, oh my gosh, I couldn't talk to my kids about that at all.
Right.
But you should. I mean, that's and some of us are a little more timid than others. And what I would tell you though is, if it's something where you don't want to have that conversation, a lot of pediatricians are very skilled at answering that question and having that discussion in a clinic setting.
And you go to med school for this. I mean, this is part of your curriculum. That's why you do some of your fellowships, you do some of your training, and these are things through your internships or whatever it may be. To get that, you got to know you got to know how to talk to people, listen, and you guys do that so well. I mean, that's we have to listen to know how to diagnose. Exactly, I guess that's how it would be. We're already on our hour. I can't believe it already. Did you get anybody who just looks like an inbox, or is it, you're going to answer your text right now?
No,
just got a text right now.
No, that's okay.
Okay, that's a good text. Could it be the wife? So Dr. Champion, I really appreciate it. Does anybody have any last ones here? It looks like everybody really enjoyed this. And again, this will be replaying and all the podcast play zones and everywhere else you get your podcasts, YouTube. Yeah. Of course, at WRBL.com, Dr. Champion. This will be, of course, living on Facebook and Twitter. It's a separate, line. But this actual physical one, we also have the full.
If you want to go another couple hours, I'm good. I've got my Brazilian bold coffee.
Oh wow!
Oh man, so
is that what you got?
That's the stuff ISIS drinks.
Wow, I believe it. Jeez, that's how they attack.
Exactly. You kidding? That Brazilian bold?
Oh my! And in fact, it has more. You should call. You should go up to some of them and say, you know what? You think you got a beat? We got Americano here.
There you go.
Triple Americano in one of these drinks. That'll get you a lot of espresso. So I appreciate everything you do. Of course, you're going to be back again because you always do pay a visit. We'll have another topic. Today was kind of all about you folks that are out there. We appreciate you guys checking in with Dr. Champion. Great questions. If we missed any, put them up here, and we'll see if we can get them for you. Spotify, iHeart, of course, anywhere else you get your podcasts, and the Play Zone. And there you have it. Instagram, Facebook, Twitter. We're going to be showing you some of these moments that we had with Hunter and the rest of his questions and some of yours, too, that were answered. And I'll tell you what, if you visit any of Hunter's stuff, if you just search on any of these, I'll bet you dollars to donuts some of those questions you're looking for. We probably answered on those, but he's your plethora of information, and it always educates me. I just love it. Very good. Thank you.
Always love being here. Thank you so much. And on the 100th episode.
That's right. And the 100th episode. You believe that? Axel, what do you think of that? You'll be back. I know you will.